Hello, welcome to this week's episode of the Baby Manual podcast. Today, I have the pleasure of speaking with Dr. Justin Rosati, MD, who is a pediatric neurologist. Dr. Rosati, can you just tell us a little bit about yourself and pediatric neurology?
Yeah, hi. Thanks for having me on. Yeah, I'm a pediatric neurologist. I actually have some specialty training in neonatal neurology and clinical neurophysiology, which means I can look at brainwaves. But yeah, I have been doing this for, now 3 full years as faculty. And I'm an assistant professor at the University of Rochester in the Department of Neurology.
That's really cool. Well, awesome. So can you just tell us about a couple of things that you see really commonly, like reasons that parents come to see you and things they can watch out for at home?
Yeah, the things that I see most as a pediatric neurologist are seizures, developmental delays, concerns, headaches, and sometimes, actually, a lot of this is kind of overlap with the developmental delays, but motor weakness, gross motor delays, speech delays, things like that.
That's cool. I know parents are often really worried about seizures, and there are a lot of things that can look like seizures. And also, if a baby is having seizures, it can be pretty serious. So maybe you can just tell parents a little bit about like what to look out for infantile spasms, for example.
So seizures really depend, different seizure types for different ages. Infantile spasms are definitely the one that we worry about most, especially in infancy. Obviously, the name infantile spasms. Typically, we see them around 4 months to 8 months, but they can go anywhere from 2 months to a year or even longer. They are very different than the traditional seizures that people think about of like the shaking, loss of consciousness type of seizures, whole body. They look like startles and they can be very subtle, often involve flexion of the head and neck. And so I'm trying to demonstrate here. But they come over and over and they're unprovoked. We often see them in clusters. So once they start, sometimes people notice them, one or two here or there. But then as they go and develop, we start to see them coming on in bunches. One of the things that is particularly noticeable or concerning with infantile spasms is once they start, we often notice a plateauing in development or even some regression. This is because the way infantile spasms work in the brain basically stops the brain from working correctly. And we can really see this progression over, days to weeks. And if not treated early, that progression can become more permanent.
And what are some things that sort of look like it? So you mentioned that it looks like startling, but startling is okay. And that is provoked by something like a sound. But
like I said, so startling, but these are unprovoked. They can sometimes look like a condition that is benign, which is sleep myoclonus. So if you've ever watched your baby go to sleep, you see them little jerks. Actually, adults do this too. And if you've ever started to fall asleep and feel like you're falling and jerk yourself awake, that's what we call a hypnic jerk, or sleep myoclonus. Those are totally normal. And if a baby is falling in and out of sleep, that's okay. But these often come when babies are awake, usually sitting up, sometimes, eating or doing things that would require them to have some level of consciousness. So if you start to see that when they're doing other things, it's definitely something that's more concerning and something to look out for. And then, like I said, an increase in the amount or coming in clusters is definitely something we look for.
one other thing that comes to mind is that when babies have reflux, sometimes they'll arch their backs, and sometimes that can sort of mimic something that looks like a seizure in adults. And that's not a seizure as well. So that's...
Yeah, very, very common question we get. And then a couple of things that can help you with that is if it's around the time of feeding, that's one. Babies will often arch and they'll get red and they can have like coughing sounds. That's two that kind of pushes you in the other direction. Though there are some cases that are a little bit more difficult, especially when a baby turns red and you're not sure if they're breathing or not. My advice for any type of seizure or abnormal movement is if you can get a video of it, grab your phone, take a quick 30 seconds to just document what you're seeing, because that helps us a ton. It'll help your pediatrician. It'll definitely help us as neurologists when you come to see us.
Yeah, that's great advice. Now, febrile seizures are actual seizures as well. Is that still 6 months to 6 years? So when we see that.
Yeah, primarily 6 months to 6 years. If it happens before 6 months, we often think about other types of epilepsies. And really, the 6 years, it should start to fade around 6 years. It's very rare to have your first febrile seizure from 5 to 6. So we usually see them mostly around, I would say, a year to 3 years. That's when the peak of febrile seizures are, and they definitely start to fade as kids get bigger.
Yeah. So a simple febrile seizure, maybe you could just sort of describe what that looks like. And I know there's often a family history as well with that.
There's two types of febrile seizures. We'll talk about simple febrile seizures first. So, simple febrile seizures are short, generalized, and those are really the two characteristics. Short being less than 5 minutes. We've sort of changed this definition over the last few years or so. It used to be, when I was a medical student, it was 15 minutes. Now we're down to 5. And generalized meaning the whole body is involved, and it doesn't start like with one arm, one leg. That then puts it into the classification of complex. So complex febrile seizures are usually longer, so longer than 5 minutes in this case. They typically have some sort of, and they could have a focal onset. So if they start with one arm or one side of the face is moving and then generalizes into a full body seizure, that makes us think more complex. And then the one other thing that could put them in the complex category, which is somewhat debatable depending on the neurologist you ask, is if you've had more than one in 24 hours. And for me, the big thing is if you've had more than one without returning to your baseline.
Now, with simple febrile seizures, I know a lot of parents, it's very scary to watch your kid having a seizure. So I always recommend, if it does happen, look at the clock, because 5 minutes can feel like a half hour. Like it can be very scary to be in that moment. But simple febrile seizures don't cause developmental delays. They don't turn into epilepsy. They don't cause any problems down the road. They don't need medications for it, things like that. I know sometimes for kids that would have more than one febrile seizure, like months or years apart, we would sometimes give a rescue medicine for seizures. Is that still done?
Mm-hmm. We tend to give the rescue medication mostly for those complex febrile seizures, especially for the long ones, because the most seizures will stop on their own within a few minutes. It is rare for a seizure to go longer than 5 minutes into what we would then categorize as status epilepticus. The reason that we would give a rescue medication, and we tend to do this more for our complex febrile seizure kids who will have, when they have their febrile seizures, they tend to be long, is to break that seizure. Usually after 3 to 5 minutes, we would recommend doing it so it doesn't end up being one of those long seizures. A lot of people ask me, how do you prevent febrile seizures? And unfortunately, kids will, if they're prone to having febrile seizures, they will just have them. You can't really pre-medicate with Tylenol or ibuprofen to try to keep the child from getting a fever when they're sick, because a couple of reasons why. One is that a febrile seizure can happen 24 hours before or after a fever. So sometimes the seizure is actually the first sign that a child is sick. And it's not uncommon that a kid will have a seizure, come to the emergency department, and then we check their temperature and it's 39 or 102. And we're like, yep, that was a febrile seizure. It's not so much the height of the fever. There are some kids that are just genetically predisposed. The brain is really overly wired at that age, so it doesn't take as much to have a seizure. But for the most part, like you said, they are usually not dangerous and they do not cause any long-term injury to the brain.
We usually also tell parents that if a child has had one febrile seizure, they are at higher risk than the general population of having another one. But it doesn't mean that they're going to have one every time they have a fever. They might just have one, or they might have one every time they get sick, or anything in between.
That's true. There are some cases, most of the time, so with febrile seizures, it is unlikely that you're going to have one with every single time that you are sick. If children do have a fever every time that they are sick, then sometimes we think about a little bit, there are certain genetic conditions that are very prone to febrile seizures. And then there is a switch the moment you have your first seizure without a fever. So once you have a seizure that is not in the setting of a fever, they're not sick, then we think about it a little bit differently. We don't always get EEGs or brainwave tests on kids with simple febrile seizures, but we often do it with kids with complex febrile seizures, and we will get one as soon as a child has a seizure without a fever.
So yeah, what other things do you think parents should know about?
Then, yeah, I think ever since becoming a parent myself, development has been a thing that has been an interesting change of pace. I mean, I learned all kinds of things about development, and I frequently see kids for developmental delays. The big things that I like to tell people, because I do get referrals for kids who aren't meeting their milestones. And the milestone checklists are a fantastic guide. They do not necessarily mean there's something wrong with your child if they do not meet a milestone. All of those milestones are ranges. And when your child starts to either miss a milestone or is behind on a milestone, there triggers a question of, okay, why is this child delayed on their milestone? And that's usually when they end up in my office. So we look at things like low muscle tone. We look at things like, was there an injury to their brain at some point, either around the time that they were born or in utero? Is there a genetic condition going on? A lot of times, I would say about half the time when kids come to see me for developmental delays, they have a totally normal neurologic examination, and it's just they need more time. But then, there's those kids who do need some further testing and workup, especially if they have low muscle tone or like pretty significant delays.
And I think some of the red flags that are sort of general red flags to look out for, if a child has a hand preference before age 2, or is only using one of their hands, that's something that you should ask the doctor about. If they're only eating food that's in pouches after a year, I get a little nervous about that, because they should be at least trying to like chew and swallow some foods at that point. Do you have other sort of general red flags that you think there might be some like a neurologic cause of that?
Yeah, other red flags are usually like lifting your head. So head lag is a big one. If you notice, like every time you're trying to pick your baby up, they're usually after about 4 months and they won't lift their head up. If they can't get their head up off of tummy time after like 2 to 3 months, that's usually a concern for me. The one that isn't a concern that I get asked about all the time is crawling. Crawling is kind of a range. Some kids will do it at like 6 months. Some kids will do it at 10 to 11 months. And some kids will skip it altogether. It's really if you have the skills around it. So crawling is great at building core strength and being able to move around. But kids sometimes figure out other ways to do that. And as long as they are building that strength and moving, then I worry a little bit less about it.
And a lot of different things count as crawling, right? So it doesn't necessarily have to be all fours, typical crawling, like they're bum shuffle, like in Bluey.
Yes.
Crawling backwards, all those.
Yeah, we think about it more of locomotion, like how you get from A to B. As long as you are able to get from A to B in some way, then that is a good sign.
Well, that's great, because you gave us some signs that parents can look for really early on to look at baby's muscle tone to make sure everything is going okay and when to ask their doctor.
1 in 26 people have epilepsy. So it is a fairly common condition. And I tell parents this all the time because, whenever we do a new diagnosis of epilepsy, we say, there's probably a kid in their classroom at school who has epilepsy. And actually, like even taking a step back, 1 in about 10 children, actually, I think it's 1 in 7 children will have a seizure at some point, which is very common. About 50% of kids, it's around 40 to 50%, will just have one seizure and never have a seizure again. So if your child has a seizure, it's not an automatic, they have epilepsy. Usually once you've had multiple seizures, then we consider you as having epilepsy.
Yeah, is it still 2 seizures kind of buys you an anti-epileptic medicine for?
Yeah, we say 2 unprovoked seizures. So if there's another reason that we could say, oh, you had a seizure. So for example, if you're a diabetic and you have a really low blood sugar and that triggered you to have a seizure, we don't count that towards your 2.
And febrile seizures don't count.
Correct. And febrile seizures are also a provoked seizure that we would not count. It's very common. Once you have 2, we would usually do some sort of evaluation. Usually you would see a neurologist. That usually involves a brainwave test, an EEG. It may or may not involve imaging of your brain. A lot of epilepsies are actually generalized, and we call them idiopathic or genetic generalized epilepsies. These are ones like people often use the term grand mal or GTC, generalized tonic-clonic. Those are fairly common genetic epilepsies syndromes. And just because they're genetic does not actually mean there's a gene. So I should, say that too. We just think that they are genetic. And most kids will outgrow those. We typically do 2 years on a seizure medication. And then after 2 years of being on a seizure medication, and you've been seizure free, we do a trial off. And some kids just never need a seizure medication again. The type of seizure that I get asked about a lot, especially in younger children, is staring spells or absence epilepsy. A lot of overlap between absence epilepsy and ADHD. And both of those things can have staring spells. And so I'll give kind of the what to look for. So absence seizures, this is the one where kids stare off for a few seconds and then come back to what they're doing. So these are very brief. So usually 5 to 10 seconds max. And they will usually stop whatever they are doing, stare straight ahead, maybe stare slightly off, and then come back to what they were doing, like as if nothing happened. It usually involves loss of time because during that, these are generalized seizures. So the whole brain is basically turned off for those 5 to 10 seconds. So they will not remember anything during that time period. After the seizure, they go right back. They don't have the typical postictal after like a generalized larger seizure with body shaking. And they can sometimes have during the seizure things that we call automatisms. So sometimes it can be like lip smacking, eye blinking, and sometimes like grimacing, sniffing, things that seem like they're automatic and they seem odd, and they might not remember that. And then they go right back to doing what they're doing. Longer spells, so things that are, a minute plus, usually we are less concerned with. And the one thing you can do as a parent or a teacher is, so calling somebody's name for a staring spell doesn't really break them out of it, even an inattentive one. But tapping on their forehead or even blowing into their eyes, if they blink and react, then it's not a seizure.
I get asked a lot about migraines. Should we talk a little bit about migraines? And
sure.
I know like abdominal migraines is a new thing, and cyclic vomiting syndrome. Not that it's a new thing that exists, but a new name for it.
Mm-hmm. Yeah. Migraines are super common. About 1 in 5 people have migraines. So it is one of the more common neurologic conditions. In general, a migraine, for our classic definition, is usually a unilateral headache. It could be both sides, but usually starts unilateral. It's a throbbing type of headache. It often comes with what we call photophobia, so sensitivity to lights, phonophobia, sensitivity to sounds. Nausea, can sometimes have vomiting. They last usually like half an hour to a couple of hours. And they often are treated pretty well by just ibuprofen. Some people have I think there is often a understanding about migraine. Migraine is a type of headache, not the severity of the headache. So there are, as a neurologist, I hear this all the time, is a parent will come in with a child who is describing a migraine headache. And then I'll ask the parents, because they are typically genetic. I said, do you have migraines? And they say no. And then the visit will go on and they were like, well, I get like normal headaches. And I'm like, well, you also have migraines. There's no such thing as a normal headache. And growing up, I have migraines myself, and I had no idea I had migraines until medical school, because my mom was always like, "Oh yeah, we just get headaches. That's just like a thing." And didn't
It's funny, me
realize.
too, actually. Yeah, same
It's
thing.
crazy.
I figured it out in medical school. Like, oh wow, this.
I think,
but it happens to children.
Oh yeah. I think once a year I diagnose like a handful of medical students with migraines, because we'll talk about migraines and they'll be like, I don't have migraines, and then they'll describe their headaches to me, and I'm like, you have migraines. But yeah, so and then there's migraines with aura, which there various auras. So the most common one we hear about is the visual auras, so spots, wavy lines. Sometimes some people see like flashes of color. Then there are the more sensory auras. So sometimes you'll get tinglies down an arm or a leg before a headache. Usually the auras are before, but they can be like during the beginning of the headache. And then there are the more severe kind of hemiplegic type migraines, where you can actually have weakness of like a whole side of your body. Those are typically genetic. Those we absolutely look into a little bit more. But interestingly, in kids, so we talk about migraines, most of the time we think about, it's very hard to describe this kind of headache. But in kids, there are a lot of things that we've actually found turn into migraines. So like you brought up, abdominal migraines, cyclic vomiting, car sickness. Yeah.
I had that when I was a kid.
There you go.
Yeah.
Even colic has been tied to migraines. I mean, these are not like one-to-one, like a kid with colic will have it, but looking back, like a lot of people with migraines had colic as babies, and the rates are just higher. There are a couple of weird things in late infancy, early toddlerhood that can be precursor to migraines. So there's a condition called benign paroxysmal torticollis, where suddenly a kid will just turn their head to the side, and could last like an hour, and it's like, what is going on? And it's actually they're having sort of this like vestibular syndrome they're trying to correct for.
Mm-hmm.
The other is a condition called paroxysmal vertigo of childhood. It's also very scary. Kids, usually toddlers, will like suddenly be unable to walk. They can have nystagmus, or their eyes can be shaking, and they will vomit with this. And they just will like turn pale. And a lot of times we end up admitting children with like this, because it can be very scary when it first happens. But these syndromes, often if you have cyclic vomiting, if you see these paroxysmal vertigo, if there's a strong family history of migraines, we will sometimes treat it as migraine headache and see if that actually makes things better.
Yeah, with those sorts of syndromes, do you end up just sort of treating supportively with like medicines that help with the nausea and vomiting, and ibuprofen for headaches?
Yeah, usually in the young kids, we'll try acetaminophen and ibuprofen. Sometimes we'll add like an anti-nausea medication as well. Some anti-nausea medications actually work really well for migraines, and even in the absence of some of those typical pain relieving medications.
Like Zofran, right?
Yeah, Zofran. Compazine actually works really well, but
also for car sickness, right?
Yes. It's
one of those like it hits all the receptors in the brain and the gut to help with
yeah, it's all that. It's a little bit of all those serotonin receptors. For older kids, we'll sometimes use abortive. We can use a mixture of abortive medications like triptans, so like Imitrex. And then for younger kids, we don't really have as many options. We typically don't do like daily migraine medications unless the migraines are to the point where they are becoming debilitating. In kids under the age of 10 or so, we don't have that many options. The mainstay option that we use is usually cyproheptadine, periactin. It's an appetite stimulator, but it also works on all those serotonin receptors. So it does do really well. We tend to, with migraines in children, we tend to start with some of the basic, like what we call lifestyle interventions. So the big five, I would say, are sleep, hydration, nutrition, caffeine, and exercise. And that would be getting enough sleep. We, especially kids, usually in the adolescent era, start to not sleep as well. School schedules kind of change, circadian rhythms change. And so there's often not as much sleep. Devices, social media, those kind of things also add to that. And so we usually say, make sure that kids don't have their phones or devices when they're going to bed. Nutrition, not so much as like, eating the right foods, but just eating consistently. I would say the biggest trigger I see for a lot of kids is they don't eat breakfast in the morning. And some kids don't even eat lunch at school. I don't know how they make it through the day, but that is a big thing. And then not drinking enough water. I would say like most teenagers especially are just dehydrated all the time. Kids in general dehydrated all the time. Do they not want to go to the bathroom at school? There's usually a multitude of reasons, but just making sure they have a water bottle is a key. And then drinking too much caffeine. Caffeine can help with headaches. It's interesting, a lot of over-the-counter headache medicines have caffeine in them. But if you overuse it, not only does it affect your sleep, but it also cause a dependency on the caffeine. And so you'll start having overuse headaches. You'll have chronic daily headaches that are a little different. And just improving exercise tends to be good for everybody.
Thank you so much. Is there any other things we should talk about? I feel like we covered.
I'll give you my little spiel on head trauma in toddlers, so that way we cover it. But because I get asked about this all the time, when do you need to worry about your kid hitting their head? I usually tell this to a lot of my parents all the time. Toddlers fall and older kids fall, and they hit their heads a lot. And I usually say the skull is hard for a reason. But there's a couple of red flags that you do need to think about. Like bring them to the hospital. Like just get them checked out immediately is one, if they lose consciousness. So if they hit their head and they are out cold, that is something that you need to check on. If they hit their head and they are then nauseous and vomit afterwards, that's something that you should probably get checked out. And then the third one is just change in their. So sometimes there will be a head injury and maybe they're dazed and a little out of it. If that persists, that's definitely something you should check on. Most head injuries, they can cause some headaches, potentially lead to concussions. But concussions, again, concussions an interesting thing because it doesn't actually, it's not the degree of the head injury. So anybody can get a concussion with a small head injury versus a large head injury. So that's not really what we worry about. We worry about more of like, did they hit their head hard enough that they cause some bleeding in the brain? And if there is, like, do we need to act on it? And that's one thing to really make sure of. If a child falls, hits their head, cries for a minute, but keeps going and they're back to themselves, you can just kind of watch them and make sure they're okay. Also, old wives' tale that if you hit your head, you need to keep somebody awake. That's actually bad for head injuries. As long as they didn't pass out to begin with, then you don't have to like keep them up all night to make sure they're not going to.
And a lot of kids do get tired after a head injury. They cry a lot and then they're wiped out and they want to sleep. So let them rest. With the vomiting, I tell parents 2 or more times, just because also a lot of young children, toddlers fall down the stairs, I feel like all the time, or have, similar type of falls, and they'll cry. And sometimes they get so upset while they're crying, they like gulp air and they throw up. So if it's that sort of a thing, that's why, 2 or more times, because one time could a lot of times just be that they're so upset that they threw up.
Yeah, I tend to more think like if they're dazed and out of it and they just start vomiting, yeah, that's a little bit more scary than the hyperventilating, I can't breathe, and then, I throwing up.
Yeah. And then also if they're walking crooked or using one side of their body differently than the other, if they have a sudden personality change after a head injury, those are all kind of red flags I tell parents to watch out for. I had learned that if a head injury is going to come with serious symptoms, it's always in the first 24 hours and typically in the first 6. Is that still a good guideline?
Yeah, that's generally the guidelines that we use. We often will, even if there is a head bleed inside the head for whatever reason, like a hematoma, hemorrhage, whatever, we typically will make sure that there's at least 6 hours of stability on imaging before we, we'll say that it's stopped doing what it's doing. But yeah, that's a pretty good.
Cool. So yeah, if it happens at bedtime, maybe be safe and get it checked out, or at least sleep in the same room as your child in case they are vomiting in the middle of the night. I feel like we covered like the entirety of pediatric neurology. This was amazing.
If only. Oh my goodness.
I know, right?
But no, I'll give you some closing recommendations, and this is just anything neurologic, because we see a lot of weird movements, we see a lot of concerns. Always video whatever you're concerned about. We live in an era where we have video machines in our pockets, which is what previous generations didn't have. So if it's a funny walk, if it is a weird behavior, if it is a staring spell, if it is something that's concerning for a seizure for you, just videotape it. It helps us immensely when you come in for a visit. People often I can't tell you how many times you see something and then you try to explain it and then your explanation just changes and changes over time, especially as you're telling different people. And it is just way more helpful if we see exactly what you are worried about.
Awesome. Well, thanks. Everyone here, you should follow Dr. Rosati on social media. That is where we first met in the first place. So we'll put some links below that people can find you. You have so many amazing videos that are a minute long that just give so much information all in one. So yeah, thank you so much for being here. This is really a pleasure.
Well, thank you so much for having me. I hope we covered enough for your listeners.
Right. I think so. Awesome. Well, take care. Thank you so much for being here. Hey, if you could, hit that like and subscribe button so that you'll be the first to know when new episodes come out. It will also help other parents like yourself to be able to find the Baby Manual podcast. You can also listen to the first 4 seasons of this podcast on your favorite podcasting platform. It's available on all of them. And you can also check out my YouTube channel. I have lots of videos and shorts that will help you feel empowered as a new parent as I talk about all the common stuff that comes up in the first couple of years of life. Thank you so much. Have a wonderful day.